Okay, screen therida.
There is, sir.
Okay. So biliary system. So biliary system, anatomy and physiology. So as we all know, biliary system has a lot of variations in anatomy and physiology. 1 minute.
Hello.
Okay. So it has got a lot of variations in anatomy and physiology. So anatomical variations in biliary anatomy are commonly occurring in up to 30% of patients. Bile ducts, either intrahepatic or extrahepatic, lie superior to the corresponding portal vein, which in turn are lateral and inferior to the arterial supply. So this concept we already saw in the last chapter. So it's very important relation, frequently asked MCQ. So I'm audible, right? Hello?
Yeah,
Okay. So they lie superior to the corresponding portal vein, which in turn are lateral and inferior to the arterial supply. The left hepatic duct remains a longer transverse extrahepatic portion and travels under the edge of the segment 4. So left is longer and it travels under segment of 4 of the liver. Left duct drains 1, 2, 3 and 4 with the most distal branch draining the segment 4A. Further supralateral, the ducts draining the segment 4B. So the most distal branch will drain 4A and supralateral will drain 4B. So that is also very important. So next is the caudate lobe drains through smaller ducts and that enter the right and left hepatic duct system. So caudate has dual drainage. So the drainage of the right duct system includes segment 5, 6, 8, 7 and 8. This is substantially shorter than the left. So left is long and horizontal, right is shorter. So right will bifurcate immediately into right posterior and anterior sectoral ducts. So which creates this short right hepatic duct. So the anterior sectoral ducts runs vertically and posterior sectoral ducts will run in a horizontal direction. So gallbladder is partially intraperitoneal structure that lies attached to the undersurface of the liver on the segment 4B and 5. So that is important because in radical cholecystectomy, we will remove segment 4B and 5. So the gallbladder length is 7 to 10 centimeters. It can hold 30 to 60 ml of bile as a reservoir and is divided into neck, infundibulum with Hartmann's pouch, body and fundus. So on the side of the gallbladder that is attached to the liver, there is no peritoneal covering. A fibrous lining known as cystic plate occupies this space. So already we saw in last chapter, there are 3 plates, cystic plate, hilar plate and umbilical plate. So cystic plate is occupied by gallbladder. So next, cystic duct. The length of cystic duct is 1 to 5 centimeters in length. And there are variations in the insertion of the cystic duct into right hepatic duct. So next page, they have given an image. I'll come to that. So next is valves of Heaster. This is important MCQ. So valves of Heaster, they are not anatomical valves. Rather, they are functional valves. So they are folds of mucosa oriented in spiral pattern within the neck of the gallbladder. The function of valves of Heaster is to retain the bile in the gallbladder until the contraction in response to enteric stimulation. So it will serve to retain the bile until the enteric stimulation has occurred. So only after enteric stimulation has occurred, it will release the bile. And important is, it is only a functional valve. It is not an anatomical valve. So next is the CBD. CBD is divided into 3 portions: supraduodenal, retroduodenal, and pancreatic portions. So next point is the common hepatic duct drains the left and right hepatic
Javin,
break out nalla voice.
And their confluence
Juin
hilar plate, which is an extension of glycerin. Voice break out, sir. Or
samaya break out.
Okay, work avula. Mobile data la dhaan poittu irukku.
Okay.
Ipo okay sir?
Ipo okay.
Okay. Okay, disturbance irundhuchna solunga sir.
Okay.
Okay, so common hepatic duct. So the confluence of common hepatic duct, that is right and left hepatic duct forming the common hepatic duct at the hilar plate, is covered by extension of Glissen's capsule. So there are generally no vascular structures overlying the bile duct at this location. So this is very important MCQ. So at the base of segment 4, the base of segment 4 of liver is avascular. So it will help to enter the bifurcation surgically. So we can incise the base of the segment 4 without damaging any vascular structure, and lifting the liver off these structures can be achieved by incising base of segment 4. This technique is called lowering the hilar plate, and it is used to expose the proximal extrahepatic biliary tree. So this is a very important surgical point. Next is vascular anatomy. So this is the variants of the cystic duct, which we earlier mentioned. So it can be normal, or it can wind around posteriorly, or there can be absence of cystic duct, or there can be low insertion, or it can be low insertion with combination or attachment to the CBD, or there can be aberrant right posterior sectoral duct, which is draining into the cystic duct. So coming back to vascular anatomy, cystic artery. Cystic artery normally arises from the right hepatic artery, and it is similar to the variability of the cystic duct. So it arises from right hepatic. It may arise from either right hepatic, either left hepatic, proper hepatic, common hepatic, gastroduodenal, or superior mesenteric. So cystic artery can arise from all these arteries. Cystic artery can pass posterior or anterior to the CBD to supply the gallbladder. Although variable, the cystic artery generally lies superior to the cystic duct. So, and there is also lymph node of Callet in that area. So next, blood supply of the common hepatic duct and common bile duct arises from right hepatic artery and cystic artery. So this is also a very important point. The right hepatic artery passes posterior to the common hepatic duct to supply the right lobe of the liver. It passes through the triangle of Callet's. So after crossing the duct, the cystic artery takes off from the right hepatic artery in this triangle. So in the cystic Callet's triangle, right hepatic artery will give rise to cystic artery. So it is important to remember that in 20% of population, there is an accessory or replaced right hepatic artery passing through the portocaval space and ascending to the right lobe along the lateral aspect of CBD. So usually artery will be on the left side of CBD, but if it is aberrant artery, it will be on the right side, lateral aspect of the hepatoduodenal ligament. So pulsatile structure palpated on the lateralmost aspect of the porta during Pringle's maneuver will identify this anomaly. So next, in addition, it can be noted on CT as a vessel passing transversely between the portal vein and inferior vena cava behind the head of pancreas. So right to left orientation is it is on the rightmost, lateralmost aspect. Anterior posterior orientation is it is between the portal vein and inferior vena cava, and it is behind the head of pancreas. That is also very important. Okay, voice sir clear arkada? Okay va?
Okay.
Yeah, okay. So next is
இதுல அந்த ஹெபடோசிஸ்டிக் ட்ரையாங்கிள் மாதிரி கொடுக்கல, வெறும் கேலட் ட்ரையாங்கிள் தான் கொடுத்திருக்கான். ஆனா
பெய்லி இருக்கு சார். பெய்லில ஐ திங்க் ரெண்டும் செப்பரேட்டா கொடுத்திருக்காங்க. ஹெபடோசிஸ்டிக் ட்ரையாங்கிள் அண்ட் கேலட்ஸ் ட்ரையாங்கிள் ரெண்டும் டிஃபரண்ட்.
ஆமா, அது சரிதான் பாக்குறேன்.
போட்டோ நான் போடுறேன் சார் குரூப்ல. ஆக்சுவலா பெய்லில இதோட கொஞ்சம் எக்ஸ்ட்ரா பாயிண்ட்ஸ் இருக்கு. அந்த மில்வாக்கி கிளாசிஃபிகேஷன் அதெல்லாம் ஆக்சுவலா இதுல கொடுக்கல எஸ்ஓடிக்கு. பிக்சர் போடுறேன் குரூப்ல, டெய்லி போட்டோ போடுறேன். So next, the perfusion to the inferior bile duct below the duodenal bulb comes from the tributaries of the posterior superior pancreatico-duodenal bulb and gastroduodenal artery. So superior bile duct is supplied by right hepatic artery. Inferior bile duct is supplied by posterior superior pancreaticoduodenal and gastroduodenal artery. The small branches coalesce to form two vessels. So this is important. These two vessels run along 3 o'clock and 9 o'clock position of the CBD. So when we put incision, we should not put horizontal incision. We should only put longitudinal incision to avoid injury to the vessels. So next, physiology. Physiology is very only by bile physiology they have given here. So already we have seen it in liver. So I'll just tell the salient points. The smallest functional unit of liver is hepatic globule. It is created by 4 to 6 portal tracts and identified by its central terminal hepatic venule. So 4 to 6 portal triads will join to form hepatic globule, which is the functional unit. So the liver actually makes only a small amount of total bile salt pool used on a daily basis, because most bile salts are recycled after use in the intestine lumen, known as enterohepatic circulation. So in this image, they have shown the anomalies of the distal bile duct and the pancreatic duct. So most of the cases, there will be a communication called abnormal pancreatobiliary communication, ABPJ, abnormal pancreatobiliary junction. And the last is the pancreatic duct will join into the CBD more proximally. This is segments of liver, and this is the Callett's node in the Callett's triangle. So next, this diagram will summarize the physiology. So synthesis, it's only 0.2 to 0.6 grams per day of bile salts which are getting synthesized. So then whichever gets excreted in the small bowel, they will reach the terminal ileum, and in the terminal ileum, more than 95% of biliary secretions are reabsorbed to the portal vein. And urinary excretion is important. Less than 0.5 mg per day is urinary excretion. Fecal excretion is 0.2 to 0.6 grams per day. So how much is the secretion and the fecal excretion are the same, 0.2 to 0.6 grams per day. And biliary secretion is 12 to 36 grams per day. So that is, it's a formula. So it is the number of cycles into the bile acid pool. So bile acid pool is 3 grams, number of cycles is 4 to 12 cycles. So when we multiply 3 with 4 and 12, we'll get 12 and 36. So 12 to 36 grams per day is the secretion. So next, some points from physiology. So once the bile components are secreted into the biliary canaliculi, the tight junctions of the biliary tree will keep the components within the bile so as to prevent leak. So next, because the bile salts combine to form spherical pockets known as micelles, the salts themselves provide no osmotic activity. Instead, the cations that are secreted into the biliary tree along with the bile salt anion provides the osmotic load to draw water into the duct. So bile as such has no osmotic activity, but bile will have osmolality equal to plasma, that is around 300. The reason is because of these cations and anions. So for this reason, bile maintains an osmolality approximately comparable to that of plasma. So that is important concept. Next, so in the terminal ileum enterohepatic circulation, we know that it's transported back to the liver. And on the opposite side of the canalicular surface, so as we saw in last chapter, there is a space of Disi. So the passage of reabsorbed bile salts through the space of Disi has to be bound to albumin. So bile will get bound to albumin. It will pass the space of Disi and uptake into the hepatocyte. It occurs through a sodium dependent or sodium independent pathway. So both occurs. So less specific sodium independent pathway is a number of organic anions are transported, including indirect bilirubin. So only one thing we have to remember, I have highlighted in different colors. Sodium independent pathway is for indirect bilirubin. For others, it can be direct, sodium dependent or sodium independent pathway. Only for indirect or unconjugated bilirubin, it is sodium independent pathway. So transport of bile salt across the canalicular membrane remains the rate limiting step in bile salt excretion. So rate limiting step is canalicular membrane, crossing the canalicular membrane. So transport of bile up an extreme concentration gradient is ATP dependent. So it is, however, it is energy dependent process. So ATP is getting used. So next, one more concept. Post cholecystectomy, patient will be experiencing diarrhea. So the reason for this is, after cholecystectomy, there is no place for the bile to get stored. So all the bile will be continuously draining into the ileum, and the ileum at one particular point of time, the rate of enterohepatic circulation will get overwhelmed, so it can't get reabsorbed. So lots of bile salts will go to the colon. So because of this, there occurs diarrhea. This is the reason for diarrhea after cholecystectomy. So that's what they have told there. So when the speed of enterohepatic circulation of the bile increases and may overwhelm the ability of the thermal ileum to absorb bile salts. So the bile contains proteins, lipids, and pigments. The major lipid components of bile are phospholipids and cholesterol. So lipids not only dispose of cholesterol from low and high density lipoprotein, but also serve to protect the hepatocytes and cholangiocytes from toxic nature of bile. So the main job of the HDL and LDL, the lipids and cholesterol in the bile, is to protect the cholangiocytes from getting digested by bile. So therefore, the biliary secretion of cholesterol actually serves to excrete cholesterol from the body. So main reason why cholesterol is being secreted is for the excretion, so that to lower the cholesterol level, and another is to prevent the bile duct from toxic effect of bile. So next, aside from the absorption of nutrients from the intestinal tract, bile secretion from the liver serves as opposing function, namely excretion of toxins and metabolites from liver. So this is another function, excretion of other toxins and metabolites, like the breakdown products of drugs and all those. So bile pigments such as bilirubin are breakdown products of hemoglobin and myoglobin. So bilirubin is the breakdown product of hemoglobin. It will reach the liver. So these products are transported in the blood bound to albumin to hepatocytes. So once they reach the hepatocytes, they will be transferred into the endoplasmic reticulum and conjugated to form bilirubin glucuronide, also known as conjugated or direct bilirubin. So this happens inside the liver. So we need healthy liver for conjugated or direct bilirubin formation. So that is the main concept. So much of the bile flow is dependent on neural, hormonal, and chemical stimuli. So vagal activity induces bile secretion, as does the gastrointestinal hormone secretin. So vagal activity is responsible for bile secretion. And next, they were told about Cck function that we all know very well. Cck, secreted by the intestinal mucosa, serves to induce the biliary tree secretion and gallbladder wall contraction. And it will also cause relaxation of sphincter of Oddi. So gallbladder concentrating bile in an osmotic process performed through the active sodium transport. So already we saw we need ATP and sodium. So it is an active sodium transport. So next, increase in cholesterol and calcium concentration. Calcium leads to decreased ability of phospholipid cholesterol vesicles. So this is the reason for cholesterol stone formation due to increased cholesterol. So increased cholesterol, they get deposited and they will lead to stone formation. So next, gallbladder neck and cystic duct. Next page. So gallbladder neck and the cystic duct will also secrete glycoproteins to help protect the gallbladder from the detergent activity of bile. So already we saw cholesterol and lipids will also help help in this. So also gallbladder neck, which produce glycoproteins, will also prevent the bile duct from getting digested. These glycoproteins also promote cholesterol crystallization. So that is also one problem of glycoproteins. It will also promote stone formation. So next, capacity of gallbladder is 300 ml per day. So that we know. Next, CCK causes gallbladder contraction and it raises the intraluminal pressure up to 300 millimeter mercury. So that is one value we need to remember, 300 millimeter mercury. So we can compare with osmolarity. Osmolarity of plasma and bile is also 300 milliosmoles. This pressure is 300 millimeter mercury, and storing capacity of gallbladder is 300 ml per day. So there are 300s. So vagal activity also induces gallbladder emptying, but is less powerful stimuli to gallbladder contraction. So vagal will also produce gallbladder contraction, but the most powerful is CCK. So because it will go up to 300 millimeter mercury pressure. So during fasting, the oblique passage of bile duct through the duodenal wall and the tonicity of the sphincter prevents duodenal contents from refluxing into biliary. So when the patient is fasting, the sphincter will be in contracted state. So it won't get refluxed into the biliary tree. So duodenal contents won't pass to the biliary tree. So next is laboratory tests for biliary tree. So it's all basic only. So increase in level of bilirubin and alkaline phosphatase will be determined in a cholestatic process. So obstructive jaundice, there will be increase in conjugated bilirubin and ALP, alkaline phosphatase. Hyperbilirubinemia could be secondary to conjugated bilirubin, possibly due to obstruction or to unconjugated hyperbilirubinemia caused by increased synthesis, impaired hepatocyte uptake and of unconjugated bilirubin and decreased intracellular conjugations. So due to all these, we will have unconjugated or increased indirect bilirubin. So next is, this is one important point. So if jaundice manifests, first we should see the frenulum of the tongue. So frenulum is first manifested at the level of 2.5 mg per deciliter. So even at 2.5, the frenulum will be seen. Will be seen when the concentration is 2.5 mg per deciliter. And up more than 5 only, it will be manifested in skin. So frenulum is first, then sclera, then only skin. Sclera 2.5, skin is 5. So next, plain X-ray. Plain X-ray role in gallbladder disease is limited because most of the gallstones, 90% are radiolucent. So that percentage will come later. So the role of plain radiograph in the evaluation of biliary disease is limited to exclusion of other diagnoses like any duodenal ulcer, perforation, any small bowel obstruction. So like that, that is only the role of plain X-ray. So next is ultrasound. Ultrasound. So the study of choice for initial evaluation of jaundice, initial evaluation of biliary tree, initial investigation of choice is ultrasound. So ultrasound, it is used because the gallbladder is in superficial location and no overlying bowel gas enables its evaluation by sound waves. So it is rarely, it is mostly superficial and it is covered only by a small portion of liver. So we can, the bowel gas will not obscure the view. So next, the density of gallstones allows crisp reverberation of sound waves, showing a echogenic focus with a characteristic shadowing behind. So we call that post-acoustic shadowing. So if post-acoustic shadowing is there, it is gallstone. So they have given how to differentiate between polyp, gallstone, and sludge. So gallstone, unless if it is impacted, it will move with positional change. So if it moves with positional change, it is gallstone. If it does not move with positional change, it is polyp. So that is one point. And sludge. So sludge is, it will move very slowly with positional change and does not have the post-acoustic shadow. That is, it will not have the sharp echogenic pattern of gallbladder, gallstone. So gallstone will have a movement with positional change, will have posterior acoustic shadow, and polyp will not have movement with this thing, with the positional change. And sludge, if there is positional change, sludge will move very slowly compared to gallstone. So that is the 3 diagnoses we can easily exclude using ultrasound. So these images are very important because this NEET Super Specialty 2021, a lot of images from hepatobiliary came. So we have to get familiar with all images. So first image is CC, gallstone with posterior acoustic shadow. Next image is acute cholecystitis with the thickened gallbladder wall, which is seen with the arrows. And this image is important diagnosis, which is porcelain gallbladder. So porcelain gallbladder, we can see the curvilinear sharp echogenic focus. So that is the distinguishing feature of porcelain gallbladder. And posterior acoustic shadow, both will be there. Curvilinear echogenic focus and posterior acoustic shadow. This is HIDA scan. So HIDA scan, I'll be covering it shortly. So this is porcelain gallbladder, curvilinear echogenic focus along the entire gallbladder wall with posterior shadowing. We just saw the image. So next is HIDA scan. HIDA scan. So the failure to fill the gallbladder 2 hours after injection demonstrates obstruction of the cystic duct as seen in acute cholecystitis. So Sabiston they have given here clearly as 2 hours. I think somewhere else they have mentioned as 1.5 hours. So here we if we all follow Sabiston, it is 2 hours. So next, it can identify bile leak, which may be useful in post-operative setting to determine the gallbladder function. So mainly it is a physiological scan. We can only identify the gallbladder function, whether it is functioning normally like that. We can't identify gallstone. So that is important. So anatomical details also we cannot identify using HIDA scan. So next is CT scan. CT provides superior anatomical information and therefore is indicated when most anatomical delineation is required. So anatomical, it is only CT. So because most gallstones are radiographically isodense, so it is isodense to bile. It will be same density as that, or it will be reduced density as that of bile. It will be indistinguishable from bile. So however, because ultrasound is operator dependent and provides no anatomical reconstruction of the biliary tree, CT is used to identify the cause and the site of biliary obstruction. So that is the advantage of CT over ultrasound. We can find the site of obstruction. So triple phase CT has essentially replaced diagnostic angiography of the liver. So that is also another advantage of CT. So in the portal bifurcation, so we can see dilated biliary tree. So dilation is due to, so they are telling here in this case it is due to head of pancreas, some obstruction. So next is MRI. MRI uses water and bile to delineate the biliary tree and provides superior anatomical definition. So MRI, they are telling it is superior to CT. So MRCP, the main MCQ point is MRCP will not use any contrast. So that they will confuse us. So MRCP will use the water content in the bile as the contrast. So extremely useful in planning resection of the biliary or pancreatic neoplasm or management of complex biliary disease by the use of water content of bile. A cholangiopancreaticogram can be created. So that is the important MCQ. So this is normal MRCP. So when they will show this image and they will ask what is the contrast. So it looks like some contrast, but it is not. It is only water content of bile. So next is ERCP. ERCP, the only point is it is also diagnostic and therapeutic. So how they are doing ERCP is, it is an invasive test using endoscopy and fluoroscopy to inject contrast material through the ampulla to image biliary tree. So in ERCP, they are using contrast. MRCP, they won't use contrast. 1 minute. Okay. So screen is visible, right?
Yes, yes.
Okay. So ERCP, they will use contrast. So that is the difference. And in Colidocolithiasis, stones can be removed from the CBD. Next is PTC, percutaneous transhepatic cholangiography. So main advantage of PTC is we can use this in case ERCP fails or for more proximal stones or stones in the hepatic biliary radicals. So more proximal, we can use percutaneous transhepatic cholangiogram, and in cases where ERCP has failed. So that is only they have written here. So useful for patients with intrahepatic biliary disease in whom ERCP is not technically feasible, and PTC can decompress biliary obstruction and stent the obstruction non-operatively and can provide anatomical information. So that's regarding this. So next is intraoperative cholangiogram. So intraoperative cholangiogram, one important MCQ based point what we should know is, should we do intraoperative cholangiogram for all cases? So what is the recommendation? So recommendation is no. We need not do intraoperative cholangiogram for all cases because they have proven that doing intraoperative cholangiogram for routine all cases has not decreased the incidence of bile duct injury or detection of stones. So we only do selective cholangiogram. So selective cholangiogram is only for these cases. So this is very important box. They have repeatedly of operation, abnormal LFT, anomalous or confusing biliary anatomy, inability to perform a post-operative ERCP because of RYBG, any bariatric surgery where they have done gastrojejunostomy. So in those cases, we can't do ERCP. So in those cases, and dilated biliary tree and any suspicion of colidocolithiasis. So only for these cases, we do cholangiogram. So it is called selective cholangiography. So that is the main MCQ here. So how they are doing it with injection, catheter inserted through the cystic duct during a cholecystectomy. So many surgeons use intraoperative cholangiogram selectively. So that's what no other important point. Only the box we should study. So next, EUS, endoscopic ultrasound. So endoscopic ultrasound with the close opposition of the distal CBD and pancreas to the duodenum, sound waves penetrate the endoscopic ultrasound, provide detailed evaluation of the bile duct ampulla. So because it is close by to the duodenum, we can do this, technically feasible. So echo endoscopes are divided in those that can scan perpendicular to the long axis of the echo endoscope, known as radial. This is very important. So there is two types, radial and linear. Radial means perpendicular to the long axis of endoscope. Linear means parallel to the long axis of endoscope. So radial endoscopes are most useful for providing tomographic evaluation, whereas linear is used for interventions. Linear is for biopsy and radial is for scanning to know the anatomy. So that is important, which is these are the vast in MCQ. So next, fluorodeoxy glucose PET scan. So FDG PET scan. So it exploits the metabolic difference between a highly metabolically active tissue such as neoplasm and normal tissue with the injection of radio-labeled glucose molecule. FDG PET scan can differentiate benign and malignant lesions, detect recurrence, and identify metastasis. So only limitation is in the setting of inflammation, because inflammation will also take up the scan like a malignancy. So next to bacteriology. So bacteriology, they are telling the bile duct is not truly sterile because it is in connection with the duodenum. When the sphincters open, bacteria may enter into the bile duct. So what are the bacteria? Most common type of bacteria found in the biliary infections are Enterobacteriaceae, such as bacteroides, Klebsiella, E. coli, Enterobacter, all those. So prophylactic antibiotics should be used in most patients undergoing interventions in the biliary tree, such as ERCP or PTC, to cover the most common bacterial species. The first or second generation cephalosporins or fluoroquinolones should suffice. So for those undergoing elective laparoscopic cholecystectomy, for biliary colic, no antibiotic is necessary. So this is important MCQ. So elective cholecystectomy, we don't have to give antibiotic. So when we should give antibiotic? Antibiotic should be used for any patient with suspected or documented infection of the biliary tree, such as acute cholecystitis, ascending cholangitis, and should be chosen to cover gram-negative bacteria and anaerobes. So the important MCQ is don't need to give elective cholecystectomy. We don't need to give antibiotics. So now coming to the Colidocolithiasis, calculus biliary disease. So stones, gallstones, they are telling that there's two major stones and other is cholesterol stones. So Rajamahendran notes there is one more type of stone which is mixed stone, a combination of these two. So here actually they have not given the components of the pigment properly. So I took this from Rajamahendran notes. So black pigment stone I've written on top, insoluble bilirubin with calcium phosphate, calcium carbonate and cholesterol. And brown pigment stone, calcium palmitate, calcium stearate, calcium bilirubinate and cholesterol. So this I only taken from Rajamahendran notes only. So it's not given clearly here. So that is the difference.
I think it's given in Bile also. Bile.
Oh, okay. Bile maybe they have given. I didn't read Bile yet. So next, once the gallbladder bile is concentrated further, the absorption of water and sodium increases, and the concentration of bile increases the concentration of bile solutes and calcium. So bile salts acts to neutralize, solubilize the cholesterol. So when the ratio of cholesterol and bile salts, when the cholesterol increases, most of the cholesterol will get precipitated. So the bile will not be able to cover the entire cholesterol. So that is the main pathophysiology. So cholesterol precipitates into cholesterol crystals when the concentration in the gallbladder vesicle exceeds the solubility of cholesterol. So crystal formation is further accelerated by pronucleating agents, including glycoprotein. So we saw glycoprotein is secreted by the cystic duct and neck of the gallbladder, so which helps in preventing the bile from destroying or digesting the bile duct. This glycoprotein is a pronucleating factor, and another pronucleating factor is immunoglobulin. So increased stone formation can be seen associated with impaired gallbladder emptying, such as in prolonged fasting state. So that's why most of the patients, when the Muslim patients, when they fast after Eid, they will come with gallstone. So that is the reason behind increased stone formation in fasting because of impaired gallbladder emptying. And use of TPN and post-vagotomy and use of somatostatin analogs. So these cases also, they will form gallstones. So natural history. So before that, one small point I missed. So more than 70% of gallstones in the United States, that is in the West, is by precipitation of cholesterol and calcium, and pure cholesterol stones accounts for only less than 10%. So cholesterol and calcium. So cholesterol stones are most common in the West, but in East, in our country and all, India, the most common type of stone is pigment stone. So in pigment stone also, there is black pigment and brown pigment. So black pigment stone occur in hemolytic states. Brown pigment stone occur due to infection. So that is the difference. So natural history, stones that do not obstruct the cystic duct or pass through the entire biliary tree into the intestine without impaction do not cause any symptoms. And this percentage is important. Only 20 to 30% of patients with asymptomatic stones will develop symptoms within 20 years. So that's why if asymptomatic, it is not an indication for cholecystectomy. Asymptomatic stone, only 20 to 30% will cause symptoms over the next 20 years. So prophylactic cholecystectomy is not warranted. But what are the cases we do prophylactic cholecystectomy? So this is important MCQ. Hemolytic anemia, such as sickle cell anemia. So why they are doing is because cholecystitis can precipitate a hemolytic crisis in hemolytic anemia. So that is a sickle cell crisis, like that it will cause a crisis. So prophylactic cholecystectomy can be done. And patients with calcified gallbladder, known as porcelain gallbladder, because it is risk for gallbladder malignancy, stone larger than 2.5 centimeter. This cutoff is very important. More than 2.5 centimeter gallstone, it will lead to cancer. And those with long common channel of bile and pancreas. So I told earlier, ABPJ, we'll be seeing that later in cancer topic also. ABPJ will also cause gallbladder cancer and cholangiocarcinoma. So we have to operate in these cases. So next is, in addition, bariatric surgery, it is a controversial, but in bariatric chapter, they are given for biliopancreatic diversion, we should do even if it is asymptomatic. And for sleeve gastrectomy, no need, because we can even do ERCP in sleeve gastrectomy. RYBG, only if there is a symptom like that we should do. But for biliopancreatic diversion, even asymptomatic cases, we have to do. This is from Sabiston bariatric chapter I saw. So next, diabetic patients, they're telling the threshold should be lowered for cholecystectomy because they can gangrenous and other emphysematous cholecystectomy operative treatment. So before that, we'll just see this diagram. So in this diagram, so on the right side, there is two phases, that is crystal and liquid phase. So cholesterol is super saturated in this side. So crystallization only with stasis. So if crystals and liquid are there, only if there is stasis, there will be stone formation. In the next three phase, crystal, liquid crystals and liquid. So in this phase and liquid crystals plus liquid, in this phase, cholesterol is super saturated and unstable. Crystals will form immediately. So only in the first two, it is crystal plus liquid, only if there is no bile stasis, stones will form. So that is the image. So non-operative treatment. So non-operative treatment is dissolution therapy. So dissolution therapy is not accepted because there is 50% recurrence rate. And also shock wave, extracorporeal shock wave lithotripsy has lower recurrence rate, approximately 20%, and can be used in patients with single stone, and size criteria is there. Only 0.5 to 2 centimeter in size, we can use ESWL. So it can have 20% recurrence, and it can be only used in stones which are 0.5 to 2 centimeters.
The component used for dissolution therapy is methyl terbital ether.
Okay, sir.
Contact therapy.
Okay. Methyl terbital ether. Okay. So next, chronic cholecystitis. Recurrent attacks of biliary colic with only temporary occlusion of the cystic duct can cause inflammation and scarring of the neck of the gallbladder and cystic duct. So this is the pathology. So repeated self-limiting episodes of inflammation is called chronic cholecystitis. So pain occurring after ingestion of a fatty meal. So that is a symptom. Biliary colic will occur. And one MCQ is biliary colic is a misnomer. So it is not a colicky pain. So it is a continuous pain. So attacks, the pain generally lasts for a few hours. Pain lasting longer than 24 hours are associated with fever such as acute cholecystitis. So symptomatic stones, there is higher likelihood of complications, and so cholecystectomy is indicated. So this is not much of MCQ. So next, diagnosis. So diagnosis. So as we saw initially, ultrasound is the first line. So it is important. It provides information such as CBD dilation, gallbladder polyp, porcelain gallbladder, evidence of hepatic parenchyma processes, and cholesterolosis. Cholesterolosis, or what is cholesterolosis? It is accumulation of cholesterol found in the gallbladder. gallbladder mucosal macrophages can also be seen. So this is the image of cholesterolosis. So there's two small hyperechoic focus on the superior margin. So that is the deposition of cholesterol. Diagnosis, most of the cholestasis, see only ultrasound is enough. So that is what they're telling. Next, treatment, some free. So that the percentage is important. So acute calculus cholecystitis. So acute calculus, what we should do. So it is a blockade of the cystic duct, and it is called acute calculus cholecystitis when the blockade is by a stone. So in chronic cholecystitis or biliary colic, the blockade is temporary and repetitive, while in acute cholecystitis, blockade does not resolve, leading to inflammation and edema and subserosal hemorrhage. So in acute, the blockade does not resolve. It leads to edema and subserosal hemorrhage. In chronic, the blockade is only temporary. Eventually, acute cholecystitis becomes active gangrenous cholecystitis when complicated by infection with gas forming organism. Specific name, but gas forming organism will cause acute emphysematous cholecystitis and risk factors.
Join voice break of the.
So this is the image of gas. So next presentation, the luminal obstruction of Bile. இவங்க நான் வேற ப்ராப்பரா வரல. இப்பதான் திருப்பி பிரேக் ஆகுது. ஹலோ சார் கேக்குதா?
இப்போ கேக்குது சார்.
ஹலோ இப்போ ஓகேவா?
இப்போ கேக்குது, நல்லா கேக்குது.
இந்த ரூம் வேற ரூம் வந்துட்டேன். ஓகே, ஸ்கிரீன் தெரியுதா? ஓகே, இப்போ வாய்ஸ் ஓகே தானே? ஓகே, ஸோ presentation. So the luminal obstruction of biliary colic, same luminal obstruction of biliary colic, but associated with sufficient stasis, pressure, and bacterial inoculum creates infection and thereby inflammation, therefore progressing to acute cholecystitis. So symptoms is right upper quadrant pain of biliary colic will be accompanied by tenderness noted on palpation of the right upper quadrant. So voluntary cessation of respiration when examiner exerts constant pressure under the costal margin is known as Murphy's sign, suggesting inflammation of the visceral and parietal peritoneal surfaces. So why Murphy's sign is elicited? Because of visceral and parietal peritoneal surface which gets inflamed. Acute cholecystitis and hepatitis, acute hepatitis will show Murphy's sign. So next, this Tokyo guidelines is also not there in Sabiston. They have given in Bailey. I'll send the photo afterwards. So another guideline is AAST ESG guideline. So Tokyo guideline, there is grade 1, grade 2, grade 3. It is given in Bailey tabla column also. AAST is grade 1 to grade 5. So grade 1 being localized inflammation to grade 5. So grade 1 is localized inflammation. Grade 5 is pericholecystic abscess, bilioenteric fistula, and peritonitis. So this they asked in recent on GT from Dr. Tutorials. So pericholecystic abscess, bilioenteric fistula, peritonitis is grade 5 ESG AAST guidelines. So next, mild elevation of alkaline phosphatase, bilirubin, and transaminase levels. So that occurs only mild elevation. Jaundice in the setting of picture of acute cholecystitis is rare and should raise the suspicion of cholangitis. So acute cholecystitis patient, if suddenly he develops jaundice, we should suspect cholangitis. And one more is Mrcp syndrome. Mrcp syndrome should be suspected, in which the inflammation of a stone in the gallbladder neck leads to inflammation of the adjoining biliary system. So stone in the neck of gallbladder will compress the CVD and that will lead to jaundice. So if an acute cholangitis patient presents with jaundice, we should think about two things, cholangitis and Mrcp syndrome. Okay, voice along okay then?
Okay.
Okay. So this image is showing the acute cholecystitis with the pericholecystic fluid collection. 1 minute. So diagnosis, ultrasound can be done. So sensitivity and specificity of ultrasound is important in MCQ. So 85% sensitive, 95% specific can determine pericholecystic fluid in case of acute cases. And another important investigation for acute cholecystitis is we saw already HIDA scan. So if 2 hours the nuclear dye is not excreted in the duodenum, then it is acute cholecystitis. CT is less sensitive than ultrasound for acute cholecystitis. So this is very important. CT is important only for stone disease and for any anatomical problem. But whereas for acute cholecystitis, CT is less sensitive than ultrasound. So that can be a true or false statement. So treatment for acute is first we should do conservative management. So conservative management is nil per oral IV fluids, optimization, parenteral antibiotics. So antibiotics should cover gram-negative aerobes and most common organisms, also anaerobes and gram-positive. So we should give broad spectrum antibiotics. And timing of operation is a controversy. So timing of operation, usually they say interval cholecystectomy only 6 weeks after initial episode. But now in recent studies, we can operate in the first week. So when patient is presenting with acute cholecystitis, first 1 week we can operate. And the study also showed similar conversion rate to open, but some complication rates were high. So that was the problem. So initial non-operative therapy remains a viable option for patients who present with delayed fashion and should be decided on individual basis. So next, given the inflammatory process occurring in the porta hepatis, early conversion to open should be considered with delineation of anatomy when delineation is not clear. So we should not wait and we should not try unnecessary dissection. If we can't delineate the anatomy properly, we should open immediately. So partial cholecystectomy, that is transecting the gallbladder at the infundibulum with cauterization of the remaining mucosa, that can be done. So we will see that later on in operations. We will see that in bailout procedures. So high risk operative candidate, what we can do? We can do percutaneous cholecystostomy. So cholecystostomy tube can be inserted and we can wait for the patient to get optimized and the contents, the toxic contents to drain out, and then we can do delayed cholecystectomy 3 to 6 months after medical optimization. So that is the thing in high risk patients. So patients with cholecystostomy tube, when fluoroscopy shows a patent cystic duct, the cholecystostomy tube can be removed. So this can be asked as a question: when we should remove the cholecystostomy tube? So only when the fluoroscopy shows patent cystic duct, we have to remove the cholecystostomy tube. So next is Colidocolithiasis. So this is also a very easy topic only. So Colidocolithiasis, it is seen in up to 10% of patients undergoing biliary imaging. So incidence is 10%. Primary common duct stones arise de novo in the bile duct, and secondary stones pass from the gallbladder. So this thing, it will be ulta in gallbladder. Urinary bladder stone. Urinary bladder stone, what they will say is primary stone is the stone which passes from kidney, and secondary stone is the stone which arises due to infection in the urinary bladder itself. But here they are saying in CBD, primary stone is the stone which arises de novo due to infection, and secondary stone is stone which passes from the gallbladder. So it is just ulta for urinary bladder. So just make a note of that, be helpful. So primary common duct stones are generally brown stones because we know it is formed by infection or due to retained stent, something like that. So brown stone is the primary stone. So brown pigment stones are associated with bacterial infection where free bilirubin is formed by hydrolyzing enzymes released by the bacteria. So this free bilirubin, the bacteria will break down the bilirubin from the conjugated glucuronide, and it will cause free bilirubin precipitation. So that is the reason for brown stone, primary stone. So next is secondary stone. Secondary stone are more common in US. Retained stones are secondary stones. So after we are doing the cholecystectomy, when we find a stone within 2 years, it is retained stone. So that kind of retained stone is a secondary stone. If we find after 2 years, it is missed stone. Or it is recurrent stone. Retained stone is missed stone within 2 years. After 2 years, it is recurrent stone. So all those are secondary. So next, biliary colic due to obstructive jaundice includes darkening of the urine sclera. So this all we already know as clinical points, basic clinical points. So cholangitis. So about cholangitis, it was first described by Charcot. So the Charcot's triad. We know jaundice, upper quadrant pain, and fever. So it is due to obstruction and increased intraluminal pressure. Septic shock with mental status change occurs, and it is known as Raynaud's pentet. So if we add septic shock, that is mental state change and hypotension with Charcot's triad, it becomes Raynaud's pentet. So there is the mortality of this Raynaud's pentet is 100% without treatment. So next is diagnosis. And there's one more MCQ point about Charcot's triad. So in Charcot's triad, the least common component of Charcot's triad, it is jaundice. It is not pain or anything else. So jaundice is the least common for Charcot's triad. So I'll also now see this image. This is intraoperative cholangiogram showing Colidocolithiasis. So there's a smooth tapering at the distal CBD. So that is stone. If there is a sharp or abrupt cutoff, it is usually malignancy. So here you can see in MRCP more clearly how smooth the stone is. So here also in ERCP, we can see the small stone shadow. So these are all Colidocolithiasis images. So that's what we are seeing in diagnosis. So diagnosis, so biliary type of pain, jaundice, abnormal liver function panel, and a dilated bile duct more than 8 mm. They are all highly suggestive of Colidocolithiasis. So we don't have to do MRCP also. If we see the LFT, we are having abnormal LFT. We are seeing dilated bile duct by ultrasound. The duct is more than 8 mm. So even if these two, and patient is having biliary colic and symptoms of stone, then it could be Colidocolithiasis. We can suspect it like that. And then we can do selective cholangiogram for those patients on table.
நீ சொல்றது 8 mm அது எங்க பார்த்தேன்
சார் இங்க இருக்கு சார். சார் ஸ்கிரீன் அந்த third லைன்ல இருக்கு சார்.
ஓகே
8 mm. So 8 mm is the cutoff. So dilated bile duct in the presence of gallstone suggests Colidocolithiasis. So that is also one more thing. If in the USG
CT ல ஒரு ஃபைண்டிங் and அல்ட்ராசவுண்ட்ல ஒரு மெஷர்மென்ட். அல்ட்ராசவுண்ட் 8 mm, CT 7 mm நினைக்கிறேன். எனக்கு இது ப்ளூம்கார்ட்ல அப்படி கொடுத்திருப்பான். சரி. ஆனா வேற புக்ல ஏதோ கொடுத்திருக்கானே இல்ல பிளைலிலயும் அப்படி கொடுத்திருக்கான்னு நினைக்கிறேன்.
ஓகே சார். நான் பாக்க ரெஃபர் பண்ணி நான் போடுறேன் சார். So next another finding is in ultrasound, if there is dilated bile duct with presence of gallstone and we can suggest Colidocolithiasis. So next MRCP. MRCP is highly sensitive and specific. So to confirm, we have to do MRCP. We can suspect it using ultrasound, but confirmatory is MRCP. 90% sensitivity, 99% specificity. So sensitivity, and this is important. Also another sensitivity specificity we saw for ultrasound for acute cholecystitis, which is 85% sensitive, 95% specific for acute cholecystitis of ultrasound. For Colidocolithiasis, MRCP is 90% sensitive, 99% specific. So these percentages are important. So next, some surgeons resort to preoperative MRCP to determine the need for preoperative ERCP. So if they suspect gallstones, they will do preoperative MRCP and ERCP for clearing the CBD stones. So clearing the duct in more than 75% of patients during first procedure and 90% with repeat ERCP. So ERCP can clear 75% of patients in the first attempt, and in the second attempt up to 90% it can be cleared. So next indication for preoperative ERCP include cholangitis, biliary pancreatitis, multiple comorbids. So all those patients we have to do preoperatively because those patients, multiple comorbids, they can't tolerate another procedure. So in the initial procedure we have to clear the entire thing. So some studies have suggested that high risk of surgical site infection in patients who receive preoperative ERCP before cholecystectomy. So that is one problem. Cholecystectomy is a clean case. So in cholecystectomy, if we are doing pre-op ERCP, they are developing surgical site infection. They have shown in one study. So next, Colidocolithiasis via intraoperative cholangiogram during cholecystectomy may be managed by either CBD exploration or post-op ERCP. So that is the decision of surgeon. So intra-op, they are finding CBD stones. So either we can, one shot, we can do open CBD exploration, remove the stone, or we can close the case and then we can do post-op ERCP. So another is PTC, Percutaneous Transhepatic Cholangiogram, can also be used to treat Colidocolithiasis in the case of unsuccessful ERCP. This already we saw this point in the basic beginning. So PTC is as effective as ERCP. So it is not superior or inferior, but it is less effective for non-dilated biliary tree. So that is an important point. For dilated biliary tree, PTC and ERCP both are equally effective, but PTC is less effective if the biliary tree is not dilated. So next, in short, in patients with likelihood of CBD stones, other modalities such as ERCP or MRCP must be considered on top of ultrasound. So ERCP and MRCP is always superior to ultrasound for colidocolithiasis, but for acute cholecystitis, only ultrasound. So next, treatment of
colidocolithiasis. Endo ultrasound is the best investigation of choice for colidocolithiasis.
Okay, sir.
கொடுத்திருக்கியா கொடுத்திருக்காங்களா
இதுல ஆக்சுவலா அந்த மாதிரி கொடுக்கல சார். இதுல பிளஸ் இதுலயும் கோலிடோகோலித்தியாசிஸ்க்கு இன்வெஸ்டிகேஷன் ஆஃப் சாய்ஸ் அந்த மாதிரி எதுவும் ஸ்பெசிஃபிக்கா அவங்க கமிட் பண்ணல.
ஆனா யூஎஸ் தான் சார் மோஸ்ட் சென்சிட்டிவ் அண்ட் ஸ்பெசிஃபிக் ஆர்சிபி விட. ஆமா ஆர்சிபியோட யூஎஸ்
டெய்லில அந்த மாதிரி கொடுத்துருக்குமா என்ன தெரியல.
எந்த அல்ட்ராசவுண்ட் இதுல எங்க படிச்சதுல ஷாக்கல் போல இல்லன்னு தெரியல பாக்குறேன்.
ஓகே. So next, treatment on the generally ERCP or CBD exploration. So just like that, we can do direct CBD exploration on table or post-op ERCP. So next, another one is causes for failure of ERCP. So large stones more than 2.5 centimeters, altered gastric or duodenal anatomy like Roux-en-Y for post-bariatric surgery, impacted stones, intrahepatic stones, multiple stones are the most common causes of failure of ERCP. So all these cases we have to do exploration, bile duct exploration. So next, Gallstone Pancreas. So Gallstone Pancreas also we can suspect using ultrasound. So ultrasound showing gallstones or colidocolithiasis with the dilated CBD with patients having pancreatitis.
ஒரு क्वेश्चन கேட்டா அவரோட எய்ம்ஸ்ல வாட் இஸ் த சைஸ் ஒரு எய்ம்ஸ்ல அவரோட கேட்டா என்ன அப் டு வாட் சைஸ் கேன் பி ஒரு மல்டிபிள் சாய்ஸ் क्वेश्चन ட்ரூ ஆர் ஃபால்ஸ் மாதிரி ERCP can be done for up to 3 centimeter stones.
Oh, okay sir. Okay, so 3 centimeters we can do, but more than 2.5 centimeter na it is one of the cause for failure. So failure ஆகிறதுக்கு பெரிய சான்ஸ் இருக்கு more than 2.5 ல மேபி அப்படி சொல்றாங்க போல.
ஆனா 2.5 தான் நான் எடுத்துக்கணும்னு நினைக்கிறேன். ஏன்னா இதுல ஒரு 3-5 ஒரு பேராவே இது கொடுத்திருக்கான் ப்ளூம்கார்ட்ல. 2.5 சென்டிமீட்டர் வரைக்கும் நல்ல ரிசல்ட்ஸ் இருக்கு. அதுக்கப்புறமேல் கொஞ்சம் 3 வரைக்கும் ஓகே, 3க்கு மேல ஃபுல்லா ஒண்ணும் பண்ண முடியாதுன்னு. Okay sir.
Okay. So next, gallstone pancreatitis. So this pancreatitis due to gallstone is self-limiting. So that is an important point. It is not very severe. And recommendation is early ERCP to remove the stone. And cholecystectomy also, early cholecystectomy. That is in the same admission, same hospitalization. We should do cholecystectomy also after patient is optimized. So that is the two important MCQs. Self-limiting gallstone pancreatitis and same admission we have to do. Next, gallstone ileus. So gallstone ileus, it is usually seen in older patients with many comorbidities. They will develop a cholecystoduodenal fistula and the gallstones will go and accumulate in the ileum and cause intestinal obstruction. So when we should suspect gallstone ileus? So we should suspect gallstone ileus when patient is elderly with some history of biliary disease in the past, with no past surgical history or hernia. That is, no other obvious reasons for obstruction is there, and patient is elderly with past history of biliary disease. So in these cases, we should suspect. So gallstone only intermittently obstructs the intestine. So it is an intermittent intestinal obstruction. So a plain X-ray will show air fluid levels consisting with small bowel obstruction, although the offending stone may or may not be identified. So that is important MCQ. So in all the cases, we can't identify the stone. Most of the cases, we won't be able to identify the stone. So another one, pneumobilia. Pneumobilia is sometimes identified on CT, and it is a ubiquitous finding because of the fistula that permits the stone. So that is important. So pneumobilia is a ubiquitous finding. So treatment. So if the patient is stable enough, which most of the patients will be unstable and they will be very old, if they are medically fit to undergo major surgery, we can remove the stone, we can resect the ileum, and we can do one-stage repair of the fistula and cholecystectomy. But if the patient is not stable and if he is older and not medically fit, we should only relieve the intestinal obstruction. We should then later on only treat the fistula after the patient is optimized. So another one technical aspect is we should do longitudinal incision on the anti-mesenteric border of ileum. So not transverse, longitudinal incision. So most of the cases will be longitudinal incision only. Duodenotomy for transduodenal sphincterotomy also, they'll say longitudinal incision. So after longitudinal incision, the longitudinal incision should be done proximal to the stone, not distal, because distal to the stone, there will be edema which will obscure the stone. So proximally, we should do longitudinal incision and we should milk the stone backwards and remove the stone through the enterotomy. So another thing is 10% patients will have multiple stones. So we should inspect the full, we should do full bowel work. So next is acalculous cholecystitis.
Sir, regular stride no sir.
Enna Satya?
The regular stride no
regular stride adu idula kodukala. Pneumobilia idu
pneumobilia, polycystoduodenal fistula, adukapra intestinal obstruction.
Okay. Next one, acalculous cholecystitis. So this images paathukonga. So idu vandu gallstone in the ileum. So idu vandu fistula, cholecystoduodenal fistula, arrow mark. So acute acalculous cholecystitis. So idu vandu because of in case of terminally ill patients in intensive care units avangala, risk factors are old age, burns, trauma, prolonged TPN.
Okay. ஒரு போவரெட் சிண்ட்ரோம் ஒன்று இருக்கு, வேணா எழுதிக்கோங்க. அது வந்து டியோடினம்ல இம்பாக்ட் ஆச்சுன்னா அந்த ஸ்டோன் இருக்குல்ல, அது போவரெட் BOUVERET சிண்ட்ரோம்.
Okay sir. So another cause for acute acalculous cholecystitis is elderly, total parental nutrition, critical illness, immunosuppression, diabetes, and the presentation can be similar or more fulminant and may progress to gangrenous gallbladder. So this is the problem. It will rapidly progress to gangrenous gallbladder. So diagnosis, we can do HIDA scan. So it is just similar to this thing, acute cholecystitis. So HIDA scan will find out. So many of these patients are critically ill, raising the morbidity and mortality of surgical procedure. So percutaneous cholecystotomy should be considered. So we should do tube cholecystostomy. So next, biliary dyskinesia. Biliary dyskinesia, so it is a functional disorder of the biliary tree, and it is generally defined by gallbladder dysmotility and usually a diagnosis of exclusion. So Rome criteria, they have not given what Rome criteria is. They have only said there is one criteria called Rome criteria for biliary dyskinesia, like for irritable bowel syndrome. So same Rome criteria will also be there for biliary dyskinesia. So other diagnosis should be excluded first. So that is the main thing. So we should do CT and endoscopy. And another thing is CCK stimulated HIDA scan. So CCK stimulated HIDA scan, what they will do is they will give CCK and then do HIDA scan. So they will check for the contractility. So they will check for the ejection fraction, that is the contraction of the gallbladder. So if the ejection fraction of the gallbladder is less than 1/3 at 20 minutes after CCK administration. So this value is important. Less than 1/3 at 20 minutes after CCK administration in a patient without stone is considered diagnostic. So there is no stone, but still the ejection fraction is less than 1/3. So that is a diagnosis of biliary dyskinesia. More than 85% patients, if they are having biliary dyskinesia, 85% cases will be improved after cholecystectomy. So in non-responders, Ercp with sphincterotomy may be useful. So even after cholecystectomy, if they are not responding, we have to do sphincterotomy. So this is biliary dyskinesia. So next is sphincter of body dysfunction. So sphincter of body dysfunction is due to idiopathic or any cause, the sphincter goes for spasm. So there is no emptying of the CBD. So that is the main thing. Here also Rome 4 criteria has been used. So Rome 4 criteria, it recommends the use of the term, it does not recommend the use of the term functional. So they are telling it there may be some mechanical component also. So that is one this thing which recently been told. So symptoms, pain and recurrent pancreatitis, which usually with usual normal liver function panel. So there is one classification called Milwaukee classification for sphincter of body dysfunction that I'll send in the group. So it's not given here, it's given Bailey. So next, sphincter of body dysfunction should be suspected in patients with biliary pain and common duct diameter more than 12 mm. So
Actually,
12 mm is the
Milwaukee
cutoff.
classification is present in இதுல பெய்லில இருக்கு. இதுலனா pancreatitis chapterல இருக்கு.
Yes sir. நான் சார் அந்த டேபிள் நான் போடுறேன் சார், குரூப்ல போடுறேன்.
ரெண்டுமே கொடுத்திருப்பான். pancreasோட மில்வாக்கியும் கொடுத்திருப்பான், இதுலயே மில்வாக்கி கொடுத்திருப்பான்.
கால் ஆமா சார். biliary and pancreatic ரெண்டுமே வரும்.
ஒண்ணா கொடுத்திருப்பாங்க. ஆமா.
So diameter more than 12 mm, so that is one cutoff. So sphincter manometry testing has to be done. So sphincter pressure more than 40 preceding it will predict a good response to therapy. So if the sphincter pressure is more than 40, if we do sphincterotomy, the response will be good, or else the response will be bad. And the majority of cases, actually Bile it's given more elaborately. They'll say majority of patients even after doing sphincterotomy will not improve. Only some patients who are having high pressure like this will be improved. So that is the thing. And then one more point is objective evidence of sphincter of body dysfunction. Division of the sphincter will improve or resolve pain in 60 to 80% of the patients. But in Bile, they have given only few patients will improve. So next, primary sclerosing cholangitis. So this we know in ulcerative colitis, it will occur as an extraintestinal manifestation. So ulcerative colitis in 70% of patients it will occur, and it also reveals thyroiditis. Next, 4 anatomical subtypes are there. So they are intrahepatic, extrahepatic, combined, or small duct disease. So advances at the unpredictable rate to biliary cirrhosis. So primary sclerosing cholangitis, there is the problem is it will lead to biliary cirrhosis. It can also lead to cholangiocarcinoma. So that is the problem with PSC. So clinical presentation is fatigue, pruritus, abnormal liver function, and 80% of patients will have elevated P and K. So that is important MCQ, this percentage. So number of percentage of patients who are having P and K in primary sclerosing cholangitis is 80%. So next, in ERCP, there is a beaded or chain of lake appearance. So beaded appearance, this image is PSC. So we can see small beads. That's the arrow mark. So that is beaded appearance in MRCP. Sorry, not ERCP, MRCP. So next page. So biopsy finding is onion skin concentric periductal fibrosis. So this is important MCQ, onion skin periductal fibrosis in biopsy. So associated with cholangiocarcinoma. So treatment is the definitive treatment for PSC is only liver transplant. So and instead of liver transplant, other methods can be used temporarily, but curative is liver transplant. So ongoing trials in PSC, ursodeoxycholic acid homologs, antibiotics to alter microbiome. So these are all only experimental level things, UDCA and antibiotics and all. So balloon dilation of dominant stricture. So if there is only single short stricture which is dominant, we can dilate with balloon. And surgical treatment includes biliary reconstruction in symptomatic patients with focal extrahepatic disease. So even this surgery, only if the disease is focal and extrahepatic, we can do the surgery. And these patients will be needing repeat operations. So it is not a one-step cure. So definitive treatment is liver transplant. So next, although it is associated with ulcerative colitis, a proctocolectomy does not appear to affect biliary disease. So this also, therefore, in ulcerative colitis, there is a tableau column in Bailey. So what are all the diseases which will improve with the surgery? That is, what are all the diseases which are associated with the disease process? So this is not associated with disease process. So even if we cure ulcerative colitis, primary sclerosing cholangitis won't be cured. So orthotopic liver transplantation is the only life saving. So they are repeatedly telling that. So 5-year survival, it ranges from 75 to 85% if we do this thing, liver transplant for PSC. So cholangiocarcinoma in PSC is generally considered contraindication to transplant. But if the patient develops cholangiocarcinoma, we should not transplant. So limited hilar disease who undergo neoadjuvant protocol. So this is an experimental trial which is going on. So if cholangiocarcinoma is limited with limited hilar disease, they are trying neoadjuvant chemotherapy and then transplant. So this is not the standard of care, but trial is going on. So this is limited to experimental trial. After liver transplant, 10 to 30% of PSC patients develop recurrent biliary strictures. So that is also important. Even after transplant, the disease will recur in 10 to 30% of patients. So it is a very bad disease to have. So retransplantation can be done, but retransplantation will increase the morbidity and mortality. So even after transplant, if recurrence comes, we can do retransplant if donor is available, but morbidity, mortality is high. So this is about primary sclerosing cholangitis. So next is biliary stricture and colidocal cyst. So we'll finish with colidocal cyst today. So biliary stricture, biliary stricture can occur anywhere along the intrahepatic or extrahepatic portion of the biliary tree. So this stricture, they are telling about only benign stricture they are discussing here. So intrahepatic strictures are usually a result of cholangiohepatitis or ischemic events. And chronic pancreatitis will also cause distal CBD stricture. So stricture in the intrapancreatic portion of CBD, it is usually 2 to 4 centimeters long and gradually tapers. So important feature of benign stricture is gradual tapering. Abrupt cutoff is a feature of malignant stricture. So most common reason is iatrogenic and post-cholecystectomy. And Mrcp syndrome, alternatively, Mrcp syndrome is a large stone in Hartmann's, so that we already know, which is obstructing the CBD. That will also cause a stricture. So impacted gallstones in the neck of the cystic duct. The resultant inflammation can cause colidocoduodenal fistula. The treatment of Mrcp syndrome is cholecystectomy, which may require repair of the common bile duct. When large fistula exists, the colidocogynostomy may be necessary. So next is long-standing colidocolithiasis. So long-standing colidocolithiasis can cause fibrosis and stricture. So ERCP sphincterotomy can be tried, or if ERCP fails, we should do endoscopic and percutaneous drainage. So another thing is Roux-en-Y jejunal limb. So what we can do is, when all these are unsuccessful, we can do anastomosis of the biliary tree to Roux-en-Y. Roux-en-Y hepaticojejunostomy can be done, bypassing the entire stricture segment. So that success is almost 90%. So biliary cyst is colidocal cyst. So colidocal cyst is most common in female and most common in the Asian population. So there is one classification. So actually this classification is called Todani modification of Alonso-Tej classification. So this name is given in Shackelford. So I refer Shackelford for this because here it is not given properly. So this classification, this is the diagram. So this is actually a very simplified classification. In Shackelford, they have given type 1, there are type 1A, 1B, 1C, and even for type 4, there is 4A, 4B. So type 1 is diffuse fusiform enlargement of the entire CBD. Type 2 is just like a small diverticulum. It is also called accessory gallbladder. Type 3 is colidococcele. You can see near the duodenal attachment, there is a cystic dilation. So colidococcele. And type 4 is both intrahepatic and extrahepatic. And type 5 is only intrahepatic.
அதுல ஒன்னொன்னு இருக்கு, டைப் 1D ன்னு ஒன்னு இருக்கு. ஆக்சுவலா தட் இஸ் சிஸ்டிக் டக்ட் இஸ் டைரக்ட்லி இன்சர்ட்டிங் ஆன் தி இது.
ஓகே ஓகே சார். சோ 1D வரைக்கும் இருக்கு.
ஆனா பட் இதெல்லாம் 1A 1B எல்லாம் கேட்கவும் மாட்டாங்க. மெயினா
வந்து
எதுக்குனா
அந்த ABPJ abnormal pancreatobiliary junction வந்து
ABPJ க்கு தான். ஆமா ஆமா.
ஆமா சார். So ABPJ is seen in 90% of cases with type 1 and type 4. So actually type 1 and type 4 type 1A, 1C and 4A are associated with ABPJ. நான் மேல எழுதி இருக்கேன் ரெஃபர் பண்ணி. So 1A, 1C and 4A. So these three types are associated with ABPJ. 1B and 4B அப்படி ஞாபகம் வச்சுக்கலாம். 1B and 4B அது வந்து is not associated with ABPJ. So அதுக்காக தான் ABCன்னு பிரிக்கிறாங்க. So next வந்து presentation, clinical features. So, type 2 and 3 ABPJ கிடையாது. So it will be useful for treatment aspect. So clinical presentation ல வந்து jaundice is the most consistent symptom and other symptoms are right upper quadrant pain and palpable mass. So most consistent வந்து jaundice தான்.
இது இம்பார்ட்டன்ட். 4A 4B மட்டும் கொஞ்சம் பாத்துக்கணும். 4A வந்து எல்லா செக்மெண்ட்டுமே இன்ட்ராஹெபாட்டிக் அண்ட் எக்ஸ்ட்ராஹெபாட்டிக் இன்வால்வ் ஆகும்.
ஓகே சார்.
4B மட்டும் எக்ஸ்ட்ரா.
only extrahepatic.
4A னா ஆல் ஞாபகம் வச்சுக்கலாம்.
A for all. Okay okay.
Actually இங்க டயகிராம் கொஞ்சம் டஃபா இருக்கு சார். டைப் 5 க்கு வந்து அவங்க எக்ஸ்ட்ராஹெபாட்டிக் போட்டுட்டாங்க. டைப் 9 வந்து only intrahepatic பெரிஸ்டோல்.
கொரோலிஸ் மட்டும் தான் டைப் 5.
ஆமா ஆக்சுவலா இது வந்து டைப் 4B. இது சார் சொன்ன மாதிரி 4B தான் only extrahepatic.
4B சார். 4B
தான் மாத்தி கொடுத்திருக்கான்.
ஆமா 4A வந்து ரைட் ஹேண்ட் சைடுல இருக்கு. 4B வந்து இந்த 5 னு போட்றது 4B. அப்புறம் டைப் 5 வந்து only intrahepatic Caroli's disease. So next வந்து it can cause liver injury and even cirrhosis. So suspected cases CT and further ERCP MRCP can be done for diagnosis. ERCP is more useful for defining the biliary tree and pancreaticobiliary junction. So ABPJ க்கு, which is the important investigation keta, it is ERCP. So incidence of malignancy 5 to 30% incidence of malignancy. It is most commonly occurring in the 7th decade, almost exclusively occurring in type 1 and 4. So 1 வந்து except for 1B and 4B, மீதி எல்லாம் types 1A, 1C, 4A எல்லாத்துலயுமே there is ABPJ and increased risk of malignancy. ABPJ இருந்தா there is increased risk of malignancy. So treatment அதை தான் வரும். So type 1 there is ABPJ. So நம்ம complete radical excision மாதிரி complete surgical excision, cholecystectomy, Roux-en-Y hepaticojejunostomy, all should be done. So cholecystectomy, அப்புறம் the margins should involve undilated, non-dilated biliary tree. So எங்க வரைக்கும் dilate இருக்கும் till that we have to remove. அப்புறம் Roux-en-Y hepaticojejunostomy. So that is to prevent further development of malignancy from ABPJ. So type 2, type 3 easy because there is no ABPJ. Type 2 வந்து it is just a saccular dilation, so just remove that excision of the cyst only. Type 3 வந்து we can do ERCP மட்டுமே will be sufficient because there is no ABPJ, there is no risk of malignancy. So ERCP stenting for drainage. If ERCP can't be done, we can do transduodenal excision. So that's type 3. Type 4 again there is ABPJ. So type 4A la we have to do similar to type 1. Entire excision of the entire dilated part, cholecystectomy, Roux-en-Y hepaticojejunostomy. So 4A la if there is localized hepatic involvement na we can do hepatectomy. Or diffuse hepatic involvement na transplant can be done. Adhe da for 4B. 4B on the easy. Only the extrahepatic are involved and there is no risk of ABPJ, so only excision. So similarly, Caroli's disease, type 5. If it is involved only part of the liver, na hepatectomy can be done. Entire liver is involved, na we have to do liver transplant. So tomorrow I'll start from the next page. The polypoid lesions, surgery, cholecystectomy.
வேற இந்த கிளாசிஃபிகேஷன் கொடுத்திருக்கேன்னா லுட்விக் ஸ்டேஜிங் சொல்லிட்டு பிஎஸ்சிக்கு.
ஓகே, இதுல இல்ல சார், சாபிஸ்டன்ல
பெய்லியில இருக்கு, அது இம்பார்ட்டன்ட் பார்க்கணும்.
ஓகே சார், ஓகே சார். நான் அந்த பெய்லியில இருக்க எக்ஸ்ட்ரா டேபிள்ஸ் கிளாசிஃபிகேஷன்லாம் இப்ப போட்டோ போட்டுறேன்.
ஓகே, சரி, ஓகே ஜான், थैंक यू.
ஓகே, ஓகே சார், थैंक यू.
Thank you, sir.
Thank you, thank you.